great pleasure to welcome you here this morning and to say thanks to our hosts, NHS Scotland, the Scottish Government, and the UCL Institute of Health Equity, and of course, the UK and Ireland Public Health Inequalities collaboration. As you heard from Michael this morning, this was an idea that was generated a few months ago, and I am so pleased that our Scottish colleagues have really taken the leadership in getting us started with a very tangible outcome of this collaboration and to stimulate fantastic discussions this morning on early years. Now, there are a number of themes which are emerging since the beginning of the day. We started great presentations this morning on childhood poverty, the determinants of childhood poverty, the trajectory of childhood poverty, and the impact thereof. We also heard from Mark Bellis looking at other adverse childhood experiences and what that could mean in terms of opportunities for intervention, but again looking at their impact across the life course and their ACEs as a determinant of non-communicable diseases. And of course, we heard from the Children and Young People's Commissioner here in Scotland, and to think about ways in which we can think more holistically about responding to the challenges and the key role of leadership, whether at national level or at local level or within communities, in helping us to deal with this issue in a much more systematic and impactful way. So I know a number of you had questions on what the policy response should be. And so I'm delighted that in this panel session that we'll now have for the next 45 minutes or so, we'll have a chance to hear from public health leaders from across the 5 nations to reflect on what countries are actually doing now. What are some of the opportunities and challenges? Where are some of the gaps in the responses? And having heard the presentations this morning, what does it mean for policymaking and practice moving forward? So for the session today, we'll hear from each speaker for about 7 minutes or so. We'll have some initial time for questions or comments related to that speaker, but we're going to reserve the last 20 minutes or so for an interactive discussion, engaging you as an audience with the public health leaders here on the table. So we're really looking forward to a stimulating and interactive discussion on the issues that have been covered so far. So without any further ado, I'd like to introduce our first speaker, who is Dr. Catherine Calderwood, and she's the Chief Medical Officer for the Scottish Government. Now, all of the bios are contained in your pack, so in the interest of maximizing our time, both to hear from the presenters and to stimulate discussion, I'm going to hand straight over to Catherine.
Thank you very much, Kevin, and I'm absolutely delighted to be here and to have been invited, and it will hardly surprise you to hear that as an obstetrician, actually all of what we've heard this morning is all about what I already knew about the importance of our children, and not only our children but our pregnant women, and how the early years are so important to the future life and health and well-being of the child, and then of course the subsequent adult. So as an obstetrician, my children, they understood what I did all day, because I helped the ladies with their babies in hospital. But they don't really understand this new job terribly well. So my son is 9, and he's quite an earnest little boy. We were walking into school one day, and he said, "Mummy, this new job of yours as Chief Medical Officer, it's all about making people healthy, isn't it?" I said, "Yes, it is, yes, it is." He said, "You're not going to ban sweets, are you?" So, everything in moderation, George. I said, I'm unlikely to ban wine either. So, I think the importance of our children is really the language that we need to be speaking. So they make up 1/5 of our population, and they are, we can solve many of our problems, many of our issues, many of our the difficulties in later lives, by getting it right for the child. Now, getting it right for every child is our GERFEC principle in Scotland. When I first came into Scottish Government, I said, hang on a minute, you're a bit late, actually. It's getting it right for every fetus, if you're in my world. And what we know is that uterine environment, the baby in the womb of that pregnant woman, it's hardly surprising that is not just an incubator. It doesn't just keep the baby warm and allow the baby to be fed and watered. But every aspect of that uterine environment is changing and developing that child for the future. So maternal mental health, for example. The commonest complication of pregnancy is depression. 12% of pregnant women suffer depression. Far commoner than all the things the obstetricians know all about, like preeclampsia and clots in your legs and your lungs. So if your mum has anxiety or depression during pregnancy, you are much more likely as a child to develop mental health problems as you're growing up. And in fact, studies looking at children following them to the age of 9, those children are less resilient in some of the areas that Professor Marmot was talking about earlier, much less resilient to tackle difficulties in their lives. So the uterine environment has protected some children, but also not protected others from their dealing with adverse incidents in their later life. And their physical health, if your mum has a BMI of 40 when she's pregnant, that child is 5 times more likely to die of cardiovascular disease than if the mum has a normal, healthy BMI. So I cannot really impart to everyone in this room the importance of getting it right for these babies and children, because we're holding the health of the nation and the mental and physical health and well-being of the nation in our hands. And you in this room know more about this than many other people. So Scotland, we have a child poverty strategy. It was 2014, it's been adjusted. We have a 20-year low in our child poverty in Scotland, but it's still at 14%. We are focusing on maximising household resources. Free school meals were announced by First Minister in January of this year for primary 1 to 3 children, and we already have free prescriptions in Scotland. Our Children and Young Persons Act, which of course Tam has told you about, has a named person for every child, and that has been controversial and difficult. However, I think it probably outlines the level of importance that we see in our children in Scotland, and having someone to be responsible for them, for that journey and those difficult parts of the journey that I've talked about. Early Years Change Fund was launched in June of this year, 274 million investment from Scottish Government and other partners, which is going to be giving money to projects that are really wanting to intervene in that early years period. So I think we have an understanding that all of these are important, and from Mark's talk and all of those very compelling statistics, it's the right time to intervene, it's the right time to invest. But this preventative spend is a really difficult concept for our politicians, for our policymakers, because how do we get money spent at a time that you may not see fruition in your political cycle, in a short period of time? And that's the same in anything, in business, in industry. Investing to save is a very difficult concept to sell, and yet all of us in this room know that that's the right direction. So I've touched a little bit on maternal mental health. Scottish Government has invested £85 million in a mental health strategy to look at improvement in mental health services over the next 5 years. We're working with our NHS Education Scotland colleagues to deliver the Solihull approach, which is a child and adolescent psychotherapy service which specialises in parent-infant interaction and parent-infant therapeutic interventions. So again, we are recognising that this investment at the very earliest part of life is so important. In our aspects then of health, I've touched a little bit on obesity, and 17% of our primary 1 children in Scotland are leaving primary 1 obese. Actually, our childhood obesity rates are dropping, but that is in fact only because the wealthier children are not as obese. In fact, our most deprived communities, the trajectory is up the way. So there's a real inequality there, and that gap is only going to get wider. The wealthier children are not as obese, and the poorer children are more obese than before. So that is not right, and that does not sit easy with me. Scottish Grocers Federation and Scottish Government have invested £1.5 million in a healthy eating for corner shops, for convenience stores to promote healthier choices. And there's a social media campaign, Eat Better, Feel Better, which was launched in January, again about simplifying healthy choices. Alcohol, we were just talking over coffee. Our young people are drinking less alcohol, well done them. So that 40% of, in our Scottish Adolescent Lifestyle Survey, 40% of our 15 to 17-year-olds were drinking alcohol 10 years ago, had reported drinking alcohol in the last week, and that has reduced to 17% last year. So that's a big shift, and our younger children, 13-year-olds, are also surveyed. Only 4% of them have ever tried alcohol. Again, a really significant fall over the last 10 years. So the message is getting out to our children, and perhaps better than our adults, because our adult alcohol consumption in Scotland, as you know, is increasing and continues to increase. Our numbers of young people smoking has reduced. And we're trying to promote the idea of simple physical activity and its benefits to health. You maybe are aware of a school in Stirling which started the daily mile. All children go out, spend 15 minutes either walking or running a mile in whatever weather, just put their coats on and go. Everybody feels better. The teachers go too. There is not a single primary one child that is obese in that school, and apparently the teachers are slimmer as well. So that is being robustly analysed and looked at, that data, to just see, but anecdotally, the teachers tell us the children are concentrating better when they get back to class, they feel better about themselves, and there does appear to be some change in weight. So we need to look at those data very, very well. Disappointingly, though, a little boy went to visit his new secondary school and asked in the school, so when do we do our daily mile? The local secondary school didn't know what he was talking about. So room for improvement there. And our world-leading early years collaborative in Scotland, which is the first of its kind to bring in a multi-agency focus on the early years. We are seeing very good results with income maximisation there for the families that need it. And from my world, the Maternity and Children's Quality Improvement Collaborative McQuick, we have seen an 18% reduction in stillbirths in the 3 years since we started to work in that area. We set ourselves an aim of 15%. Everybody told me I was wrong. 15% was a ridiculous number because stillbirth rates had been stable for 20 years. I was wrong. It should have been higher, but we were aiming for, because we've already surpassed our aim. So again, real inequalities in that area, which we're beginning to narrow. Thank you.
Thank you, Catherine. So I'd like to introduce Ruth Hussey, who's the Chief Medical Officer and Medical Director for Wales. Ruth, welcome.
Thank you. Well, first of all, thank you very much indeed for a very enjoyable morning, and as always, stimulating ideas in my mind about how much more we can do to tackle this enduring area of concern that we have in inequalities in health. What I thought I'd do is delve straight into some examples of picking up where people talked about, do we want more projects? What can we do systematically? How can we change policies and practice throughout? So I'm going to talk a bit about a few examples which I think may well be helping us to pave the way for what I'd call a game-changing shift in the way that we approach our decision-making. So the first thing I want to talk about is something called the Wellbeing of Future Generations legislation. If you haven't seen it or heard of it, Kathy, my colleague, who's in the middle there, has a few spare copies. This is an essential guide to it. This will be enacted next April in Wales, and this puts wellbeing at the heart of government policy making and puts a duty on public services to weigh up what they're doing to deliver the 7 overarching goals. One of those goals, people will be healthier. It links economic development with environmental resources, with cultural concerns, and with Wales as a global player. I think when they launched this last year, when it got royal assent, the UN Sustainable Development Commissioner said, where Wales is now, the world will follow tomorrow. I think it's potentially going to really change the way we think about health in all policies. It puts health outcomes in the heart of policy and practice. So that's the first thing. Secondly, well-being seems to be embedded in a lot of the legislation that we have. Another act that comes live, enacted next April, is the Social Services and Wellbeing Act. Again, prevention central to how we use resources, measured against need in communities. I haven't got time to go through it all, but again, opportunities to get over those barriers that people talked about in terms of how do we switch resources. The legislation says you can pool your budgets, you can focus, and really be person-centred for those most in need. I can go on, violence prevention legislation and so on. So what about public health actions in policies that we have in government? I could talk about the early years framework, a shared outcome framework for children and young people. Programmes reaching 25% of the population called Flying Start, offering childcare support in those early years. Families First, parenting programmes being launched as we speak. A whole range of different initiatives. The two challenges I think we've heard today, scale and universality. And when I look at what the NHS is doing, it's probably the only potentially universal service in that very first early period. My annual report published a month ago talked about the first 1,000-day campaign, and it drew an awful lot of interest because suddenly we were talking about a much earlier period in childhood. People starting to realise it is very much laid down very, very early, as Catherine has already described. So we're refashioning our Healthy Child programme, bringing into the assessment process a family resilience tool, helping health professionals ask the difficult questions, to be concerned with the issues that matter to people and their families. So I think there's a real opportunity there. Investment in perinatal mental health issues, investment in child and adolescent mental health, responding to the issues that we have as well. But I think not only do we need to look at how do we do 100% coverage, because I think our challenge is those very families who we absolutely want to make contact with to support them are likely to be the ones who can't pay the rent, who've changed their accommodation again for the 5th time in a year. And we know that those are the families perhaps who we really do need to make the most effort. So how do we get to truly be 100% universal? And I think with the change of our Healthy Child programme, there's a real opportunity to build a research and evaluation framework alongside that to really understand that. But alongside it, learning from a small piece of work called Cynefin, which is loosely translated as place, habitat, working with communities in a different way. I just want to quote two comments that came out of that work. And it wasn't particularly early years, it was more about creating healthy communities. And the public sector worker there from the council said, I've realised it's not about doing to or for a community, it's delivering services with. And I think whatever we do, we have to listen and work differently in those settings. And equally, the residents from that community talked about we would never have thought we'd have had power shifted from the authorities to our communities without the help of this worker that they described. So really rethinking, when we talk about power and control, how we can help in that conversation in the way we think and design services. Just some final points. So the health indicators we have, life expectancy improving, healthy life expectancy improving, the gap hasn't widened particularly, hasn't narrowed sufficiently, but you know, it seems as if we're making some progress. There's a worrying small trend about the prevalence of mental ill health in our overall adult statistics. And I just want to refer to the teen statistics, the school and health behaviour study, the 11 to 16-year-olds. Sharp drop in smoking, drinking, sharp drop in teenage pregnancy, sharp drop in sexual activity, sharp drop in cannabis use. Makes me think, what are we measuring and what are we looking for now? Our children are living in a cyber world. Do we understand what we should be looking for the future? What's happening there that we need to do something about? So what are the opportunities ahead of us? Can we use legislation more? We've heard today reference to legislation in the US around adverse childhood experiences. Should we explore that? How do we deliver services universally, consistently? Another area. But my final points then, what do the public understand? And I was drawn by a publication from the Scottish Government, in fact, which quoted British social attitude survey. And it says that individual explanations of poverty are more common than structural explanations, and attitudes have hardened over recent years. So 23% of people thought that people live in need because of laziness or lack of willpower. 21% thought it was due to injustice in society. We have to explain this. So one task for the public health world is to get this understanding more generally in the population. We need to listen to the next generation. Those teens now are the next parents. And we need to get alongside them In the same survey on the lifestyle behaviours, 2/3 say they get the help they need in year 11. A third have already experienced bullying. And when we look at being involved in fights, there's a sharp social gradient in terms of the proportion of children involved in fights. In the poorest communities, 14% of boys and 12% of girls say they've been involved or affected by fights. So we've got to get ahead of the curve. We've got to think through what are the conditions that as adults we're creating for the next generation. How is that going to affect them? But absolutely, we need to work with early years and get that message across to communities. Measure what matters to people, advocate by walking alongside the communities we serve, and let's use science in a cross-cutting way to truly understand what's happening. Thank you.
Wonderful, thank you so much. So our third speaker will be Owen Metcalfe, Chief Executive of the Institute of Public Health in Ireland. And again, we're hearing from each speaker for about 7 minutes, and then we'll have some time for reflection on what you've heard. Owen.
Okay, thanks, Kevin. And it's great to be here. And in a parallel analogy, I feel that I was here at the conception of this and have now been at the birth. So I hope to follow it through into a very successful adolescence, which would be brilliant. But there's a couple of words just reflecting on what's already been said. So much of this is about relationship build. And relationship build is about engagement and participation. But those things really take time. They take time to plan and they take time to execute. So I'm wondering if we can just hold those thoughts. My own influences for a better start. I did teach for a number of years, but severely influenced by the work of people like John Holt and Paul Goodman, and then Ivan Illich and Paolo Freire and even Maria Montessori, and then in the birthing process when I came to be a parent myself, and the work of Le Boyer, and even in terms of working with young people, Hobson and Scally were a byword for good quality education in the life skills environment. Turning to Ireland, we have a lot of architecture, and this is the Republic of Ireland. We've got a national policy framework for children and young people. We have a child and family agency. We've got a cabinet post. We've got longitudinal study with data. We've got a youth parliament. So there's a lot in place. But then I'm reminded of something that I've heard in this world of health inequalities. If you're doing nothing, do something. If you are doing something, do more. And if you're doing more, do it better. And I think that is something that we can really do a lot better. Even though we may have the architecture, we've got some of the building blocks, but where's the commitment to quality? A little aside, developing a national obesity policy, a lot of consultation, and really great to see one strand of the consultation process entirely focusing on young people themselves. And along with that architecture, we have a plethora of programs that are there for early years, parenting, a range of programs. A lot of them philanthropically supported. A major philanthropist in Ireland, his work is almost done. So there's a real worry about where those programs go from here. But what's the lived reality? The number of children living in consistent poverty, we've heard about this. A raw number, well, it's doubled from 6% to 12% in the recession. 135,000 children are experiencing material deprivation on a daily basis. That's 135,000. You know, that's each child having a family circumstance or having a set of circumstances. What about smoking and pregnancy? We don't have good data, but we know about the gradient there. Breastfeeding, we've got some of the worst breastfeeding rates in Europe. 56% said that they had ever breastfed 6 months. That was down to just 6%. A number of other things happening, obesity and overweight, 1 in 4 of 4-year-olds. And the Child and Family Agency, just a quantity of numbers of referrals in there in an annual basis. 231,000 child welfare referrals and 19,000 child abuse referrals annually. And we have prevalence of long-standing conditions in the primary carer, resulting in a lot of prevalence of long-standing conditions in the young people, cyclical in nature. So how are we going to do something about this? First thing is, like there's a lot of rhetoric, a lot of architecture. Are our children truly prized and valued? What is the status that attaches to childhood in our society? How is that visible and demonstrated in responsibility, posts of responsibility, in allocation of resources? I think a lot more could be done, but it's, as I said earlier, how to achieve that shift. We have a lot of data, we don't mine it. We know a lot about the commitment to systematic interventions. What is truly good quality? How do we replicate it? How do we mainstream it? How do we get it permanently throughout the structures? If you like, you can have the proportionate universalism, but we have to have universal services. I would say the economic climate has been particularly significant. It casts a long shadow in terms of the ways in which it influences, impacts families. We heard about that. And worryingly, whilst we had a lot of issues in relation to mental health for young people, particularly young males, we're now seeing an increase in suicides amongst middle-aged males. That's probably as a direct result of what happened to us during the crash from 2008 to 2013. So, yes, I would look for a whole-of-government approach, which is what is advocated in the young people's strategy. It does say, by the way, that there's an aspiration for Ireland to be the best small country in the world in which to grow up in, so maybe we can introduce a little bit of competitive rivalry there. A few other small countries around the table as well. But our public health can contribute by looking at a whole range of those areas where we can help people in other policy areas to make better decisions in housing, in education, to do with homelessness. There's a raft of areas, but you do have to be able to work collaboratively, cross-party, and that to me is really not being cracked anywhere. One example that I do really like is the example from Sweden, where they got cross-party support for 11 public health goals a number of years ago. Well, it's an example from that area where they were able to say, this is what we're going for in the public health arena, regardless of who's in power. It's going to carry on over a period of time. So I'm looking for some adherence to those kind of levels of change, a shift in investment, greater whole of government cooperation, a reality.
Wonderful. Owen, thank you so much. Mary Black is Assistant Director of Public Health in the Health and Social Wellbeing Improvement Department in the Public Health Agency of Northern Ireland. Mary.
Okay, good morning everyone. What I'm going to do is just give a little bit of context, talk about what we're actually doing, some of the barriers, and then some of the opportunities that I see for us this morning. The first thing is we're a small country. We're 1.8 million people in Northern Ireland, and that, I think, offers us something of an advantage in terms of can we do it? You know, it's a scale that feels like it is something that we could actually really make a difference on. The framework is the public health framework for Northern Ireland, making life better, with the 6 themes, the first of which is give every child the best start in life, from our dear friend, Professor Sir Michael Marmot. Now, we have that as a plank. It's a cross-government strategy. We have an interministerial group. We have a senior officials group from across departments, and we believe we have a commitment. We have yet to see that in practice, but that is our new public health framework within which everything we do will sit. As an organisation, the Public Health Agency is about 6 years old, so we're coming to this agenda following an introduction by Harry Burns, actually, the Chief Medical Officer here from Scotland, who came and spoke at West Belfast Festival, an arts festival, and that was the first time he switched people on to this early years agenda. Since then, we've had several other world experts join us and give us the benefit of their advice, and from that we've begun to shape our planning and our policy. So that's what I'm going to tell you a wee bit about, and then some of the challenges. Mark mentioned this morning the pyramid and the adverse childhood experiences, and that has really been the pyramid around which we've been focusing those efforts. We're also conscious that inequalities are widening, so whatever we do, we have to address the interventions in order to build momentum. One of the things that has an additional factor in Northern Ireland, and we're aware of it, is the impact of the conflict and the long shadow that Margaret talked about in terms of economic disadvantage. We're also seeing a long shadow of the exposure to trauma and what we need to do to systematically interrupt that process. How are we doing it? We've established a Child Development Programme Board chaired by the Director of Public Health for Northern Ireland. And on that board we have health and social care, cross-government representation, academics and special sectoral interests. We have established a number of programmes of work, the first of which is universal services in terms of children's services, Healthy Child, Healthy Future. Family nurse partnership, yes, we are growing that to scale, something like 440 involved at the moment. Breastfeeding, we have a very low level of breastfeeding. Social complexity in terms of pregnancy and a new programme to intervene with research wrapped around it. And then all those evidence-based parent support programme and growing them to scale. We have an infant mental health strategy and a programme now to implement that strategy. We have a research and evaluation programme wrapping around that, including an RCT, evaluation of infant mental health parenting programmes, intensive home visiting, Cochrane review, and the roots of empathy, which we're also introducing with a randomised controlled trial. Now, all of that is to help us learn. And it is also in testing new approaches to inform what we do in the mainstream or universal services, as we've been calling them this morning. And we have made significant new investments in the universal services as well as grow some of these new programmes. And we're aiming to intervene at the antenatal, that is, the 0 to 9 months, into the early years, into the childhood, and then into the teens. And we have a number of, as I say, without naming them all, parent programmes in those areas which we're evaluating. So in terms of the big opportunity that is just before us, that is independent funding provided by a philanthropist matched by government of 30 million over the next 3-year period. And in that programme, we have 3 work streams, the first of which is universal services. And we're looking there at early years, working with education and health to look at the investment that will bring greatest dividend in terms of antenatal opportunities for intervention, antenatal education, and then the very early education intervention in nursery education. Supporting families when problems arise before they become the need for statutory engagement, and the intensive family support programme. And then the third work stream is looking at those children where they have experienced severe adversity. So intensive family support, changing the adoption and fostering arrangements so that if people are prepared to foster, they're also prepared to adopt, so that we don't move babies around as often happens, as you'll know. Those young people who are on the edge of offending and parents who have been offenders. So a stream of programmes in that third area of the early intervention workstream programme. So what are the barriers? 1 minute. Okay, so very, very quickly, I think the big barrier is changing the culture and the understanding. We have to keep doing that because the paradigm that I think others have referred to is the investment it's long term before you see that outcome. We also have professional and organisational boundaries that we have to keep hopping over, and I wouldn't underestimate those. They can distract people, and of course in the middle of all that we have organisations reorganising. So again, all of these distractions. In terms of tackling it as a priority, our aim is to continue to build that awareness and understanding in education. We are influencing the current programme for government, and I think the contribution of a target or an investment target around early years intervention is probably one of the most powerful things that we'll aim to go for, and therefore that evidence from Mark in terms of cost effectiveness is highly, highly important. And we're also developing an adversity matrix assessment because many families are not exposed to one risk factor but several risk factors. So we're doing some research work around that. And most importantly of all, we're evaluating and being very open about what we're finding about the new programmes and the influence on the mainstream programmes. But the other big barrier, I guess, is the financial barrier, because when people are retracting, they retract to their core and they're less likely to look outwards, and this is an issue that requires us all, as you know, to stretch across and work across. So I'll leave it there, Kevin.
Wonderful.
Thanks.
Mary, thank you so much. Our final panelist is Mr. Eustace D'Souza, and Eustace is our lead for children, young people and families in Public Health England. Eustace.
That's great, Kevin, thank you. And it's been a fantastic morning, lots of challenging ideas, information, data, knowledge and intelligence. So well done to all the organisers. I hadn't really realised until listening to my colleagues speaking just how short 7 minutes is, so I'm going to speak really quickly. I just wanted to cover, thank you. I just wanted to cover a number of areas really, but before I got going, some young people reminded me that we're really quick to, they pulled me up on this last year at a conference that I was speaking at, and a couple of them came up to me later and said, you're always quick to speak about the things that are going wrong, and you never talk about things that are going right. And quite often we do that, and I think the point that that was made earlier is entirely right in terms of taking a much more asset-based approach to this. There'll be many people in this room who have grown up in adversity and in poverty and have broken through that. So that positive deviancy that Tam and others talked about earlier today. I'm not minimising the challenges, but it's important that we recognise the assets that people have as well with the appropriate support. I want to just set the context very briefly for us in PHE, in Public Health England, and obviously mimics what we've heard already today. So context of a rapidly reducing public sector finance, resources and capacity, significant variations in health outcomes both for adults and children across the country, even for local authorities with very similar demographics. We have inequalities widening for most health outcomes for children, and we've heard a classic example of that around child obesity in Scotland, and indeed it's a very similar profile for England, and that gap continues to widen at an alarming rate. And a real sense that we've got large numbers of people, as Michael was saying earlier, a large cohort of children and families who it feels like are being left behind. As we move the graph in the right direction for many children and families, actually there are many children equally who are being left behind. And that's one of the main pressures and challenges for all of us. So the way in which PHE has tried to structure itself to address some of the adverse childhood experience issues that we've described today, we've heard today, is twofold really. Firstly, it's trying to take a life course approach, an approach that is place-based and focuses on equity. So we've tried to structure ourselves in that way under Kevin's leadership, while still drawing on the professional expertise of drugs and alcohol and all the other issues that we've heard about today, taking a much more holistic approach. And the second thing is we published last October our evidence into action, setting out 7 national priorities for the country, public health priorities. And within those 7, 4 directly within this space. So a commitment to reduce harmful drinking, commitment to reduce harmful drug taking, a commitment to reduce childhood obesity, and lastly, but quite crucially, to give every child the best start in life, as measured by children ready to learn at 2 and children ready for school at 5, and everything that contributes to that, not just cognitive skills, but all the social and developmental skills that accompany and support that. So that was the approach we've taken, and there are 3 areas that we focused our energies on in working with our local and national stakeholders, with local government and with others. The first thing is about being smarter around what we're commissioning and how we deliver. And we've heard that very clearly today from the floor. With a dwindling public purse, we can't afford to continue to waste money on interventions and programs for which there's limited evidence. I'm not saying that we shouldn't encourage innovation, we should, but we're under increasing pressure to make sure that what we invest in wisely. And our role as a public health body is to shine a light on that and to advocate very clearly in a way that's communicated effectively to local government in particular about what works and why. It's about investing to save, as we've heard today from the panel. And it's also about taking a holistic approach to this. So for us to stop commissioning in silos, just, to stop commissioning just for drug treatment services and alcohol services and all the other services, but actually seeing this from a family's perspective. And that's part of the government's programme around troubled families, to see a much more holistic approach around this. The second area for our focus is around having a workforce fit for this new model, a workforce that is agile, that's flexible, that's prepared and able to work in a much more holistic way, in a multi-systemic and a multidisciplinary team, while still valuing the individual expertise, skills and professionalism of certain professions, whether it's health visitors, school nurses and so on. And I think the other thing is to recognise that public health exists everywhere. It doesn't just sit within people who have a public health qualification. I have to say that very loudly because I don't. It actually sits everywhere. And I was speaking to a group of youth workers recently and made the case to them that actually I felt that they were really strong advocates for public health youth, in youth services. The work that they do around keeping children safe, building resilience, is absolutely what we heard today from Mark and others, is central to building resilient children, resilient families, resilient communities. And the third thing that we do at a national level is working with national government and other government departments to inform and influence the shaping of policy, whether that's working on the current commitments around child obesity or drugs and alcohol and so on, and trying to ensure that the issues that we've heard today are embedded across the vast range of government policies and advice, and not restricted just to something that comes under the mantle of health with a big H, and seeing the whole issue of adverse childhood experiences in all aspects of government as we advocate in local government as well. I suppose ultimately our challenge really is to make sure that health improvement is delivered at scale in a way that reaches all families, addressing the point that Michael has raised around universal approaches, but actually that we continue to reduce the gap that unfortunately we're seeing is increasing for many of our children and families.
Wonderful. Eustace, thank you so much. Colleagues, you've heard from the various countries and you've heard some recurring themes, whether it's the importance of universality, the importance of achieving scale, thinking about ways in which we work across governments. Health in all policies certainly has been mentioned by a number of the presenters today. We've heard some of the challenges which are persisting, whether it's the widening inequalities, some of the pervasive adverse health outcomes, but we've also heard about the importance of focusing on assets and leveraging those assets at whatever level in society they're occurring to help us to achieve better outcomes. But what are we missing here? And if this was so easy, because we know it isn't, but if it was, if we seem to be having all the right ingredients, why are we not moving even faster and having even greater impact than we need to be having, either in our individual countries or across the 5 nations? What more should we be doing as we think about the next 3, 5, 10 years at a very challenging time for nations to begin thinking about protecting the assets that we have, but going further? So we have time now, about 15 minutes. We started a bit late. So I'd like to take groups of 3 questions to the panel. I won't ask each panel member to respond to every question, but we'll have a conversation. So shall we start with the first 3 questions? And there's a hand that's up already. And can I see other hands, please? Fantastic. So we have the first 3 questions.
Hi, I'm Claire Cable from excuse me, the Queen's Nursing Institute Scotland. We've started to talk through the panel about whole system approaches, assets-based approaches, place-based, which is, to me, it feels as if it has to be the way forward. In a number of communities across Scotland, including in Drumchapel in Glasgow, the community have taken the GERFEC principles, getting it right for every child, the Shanari indicators, and talked about getting it right for every community, actually applied those indicators to their own communities and said, what do we need to do as a community to make a difference? And it feels as if those kind of place-based, community-led initiatives have to be the way forward. Marion said earlier that we've had decades of community development projects, but we haven't joined them all up and made it sustainable so that communities can really make a sustainable difference themselves. The First Minister, I imagine many people in the room were at the First Minister's address at the Health and Social Care Academy inaugural lecture on making a difference to the health and well-being of the people of Scotland. And disappointingly, it was a party political broadcast on the SNP's health record. It didn't really address what do we need to do to make a difference for the communities of Scotland. So my question is, how do we create a social movement to enable communities themselves to promote well-being?
Great, thank you. And a second hand, the lady on the same table.
Thank you. I'm Mary Van Lieshout. I'm a member of the Healthy Ireland Council in Ireland, which is a whole-of-government approach to tackling and promoting health. And our second core goal is to reduce health inequalities. My concern is with something that Ruth Hussey has raised, and I think you referenced that this question came from Scotland. You talked about the barrier of public attitudes, that there is a growing number of people who believe that poverty is caused by individual circumstances rather than structural inequalities. And I think that health inequalities are growing and exist simply because they are politically acceptable. They're acceptable to a growing number of people in our communities and amongst our political leadership who place the responsibility for those inequalities in the hands of individuals for being ignorant or not doing enough. So my question is, Ruth, what will you be doing about that hardening public attitude? What have you, with that evidence, decided to do? And also a plea to my colleagues in the Department of Health that we might use that text on a question and be able to look in Ireland about those attitudes. Thanks.
Great, thank you. And the gentleman sitting in front.
My name is Diarmuid O'Donovan and I work in public health in Ireland. My question reflects the first question there and goes back to what Mark said earlier, like what we're doing is not sustainable. Ruth Hussey talked about sustainability as well. So we're all talking about improving health in a quality environment that's place-based while reducing inequalities. So could we hear a little bit more about what's happening in Wales about making the health system more sustainable while addressing some of these things and linking into other public services?
Wonderful, thank you. So Ruth, I'm going to ask if you'd be willing to kickstart with the responses, and then we'll invite colleagues too.
Okay, on the three questions then, first of all, I think we need to engage communities, work with communities, but not forget that people's living circumstances are created by the socioeconomic policies within which they live. So just need to make sure we get the balance right between people solving problems for themselves, and I did reference how we as public sector agencies must work differently with communities and truly share power, but on the other hand not forget that the living circumstances are determined by socioeconomic policies. On the public attitude thing, just to clarify, it's actually British data, but I found it in a report from Scotland, but it's British attitudes that I was quoting. What have I done? Well, I was actually inspired by some of Harry Burns' words, about how do you get the message across that what happens to children really starts very early and is something that we can do something about. And so what I've been doing is trying to frame the conversation, not in terms of why don't you pay attention to this, but in terms of the broader issue, but trying to get the message across that what happens in the first 1,000 days changes somebody's life chances. And it's actually got a lot of interest. It's something more tangible. I know I've been in rooms where when we've laid out the challenge of health inequalities, people have just sat back and realised it's the whole of society, what do we do? So I think our job is to translate it into those things where we have got some confidence that we can do something differently. So maybe something like 1,000-day campaigns helps people to sort of say, oh, I know what that now means, what I can help with in my daily life. And thirdly, on the sustainable approach to healthcare, you're absolutely right. We've got to look at the beginning of life and the end of life. I haven't got time probably now, because it would take me another few more minutes to talk about prudent healthcare, but nested within our approach to sustainable healthcare systems is not only getting the first part of life right, but also how do we address a prudent use of our healthcare resources. There's a website I can talk to over lunch if anybody's interested, but that's about 4 principles quickly. Co-production, truly shared decision-making with people who often make different decisions to the professionals. Secondly, equity and caring for those most in need first, so scaling our response appropriately. Thirdly, do no harm, do more, no less. So really thinking through what we are adding value with sometimes. And fourthly, no inappropriate variation, where we've done it because we didn't realise as opposed to choice of the people we serve.
Wonderful, thank you. So something to follow up with Ruth over lunch. would anyone else on the panel like to reflect on any of those three themes about creating social movements? Or
Yeah, I'd like to pick up the question about community, because I think it's just so fundamentally important, because the communities that we're working in are often disadvantaged. Yes, they have many assets, but they are removed, marginalised from so many avenues. The other thing that is at risk is that funding is often on a short-term basis, so that even though we might be planning in the long term, their view of what they're capable of doing is often on a short-term basis. The other difficulty is that local and understanding of the local is different than a professional view often, and you get that conflict. And you also get, yeah, but we've been doing this really good work and we know it's good, as opposed to the bright new shiny thing that's coming in because it's evidence-based and all the rest of it. So you've got those kinds of discussions to have. But fundamentally, I think you cannot get away from the need to work with people to understand and to value and respect their view on life, and use that as your starting point for moving forward. And I think there's no shortcut to that. One thing that I would say is, though, that education, that is the understanding of this agenda, is still relatively new for people, and that is often a starting point, their children.
Great. And you wanted to briefly comment, and then we'll take another round of questions.
Yeah, just to endorse what Mary said, really, and I think certainly community-based approach is the right way to go. I think there is some caution here, though, because there is the issue about, certainly the experience that we've had with the Troubled Families programme in England, is that approaching problems in silos is ineffective and can cause harm. So seeing this from a family's perspective, seeing the whole context in which people live, is absolutely crucial if we want this to work. I think the other thing is that we're all catching up with the knowledge and intelligence and the latest research, aren't we? And, talking about childhood obesity, we've seen cases where we've tried to implement healthier meals in schools, and then we have parents waiting outside school gates, feeding their children chips and Mars bars through the school gates. So there's an awful lot of education that we still need to do around this to support communities to make informed choices.
Wonderful. So I'd like to take the final round of questions. I'm going to ask colleagues to keep this brief, and then we'll have some closing reflections from the panelists based on this round of questions. So can I see your hands again? So we'll be able to take three. So who has the mic? Yeah. So if we could start here, please. Thank you.
Hello, I'm Rachel Happer. I'm a clinical psychologist who works with adolescents and trauma. And I guess one of the things I wanted to just raise was that there's a huge amount of research and interest, similar to what Tam was saying this morning, around very, very early years, the first 1,000 days. But I do think it is absolutely essential that we look at young people, because I think there is a re-emergence of many of the issues that that adversity creates in the really early years, and we have to think about what are the universal services for adolescents. Some of it will be schools, some of it will be, but I'd like to hear what you think are the places that we can actually tackle inequalities for young people.
Great, thank you. At the front here, please. Anne-Marie, did you? You've yielded, okay. On this, I'm sorry. Thank you.
Just following up on the place-based approach that's been mentioned already, Harry Burns wrote the foreword to another report called Good Places, Better Health for Children. And just in relation to that mile as part of the school day, my question is, can we not make the streets safer for our children in terms of speed limits and quality of place to encourage them to be able to walk that mile with their younger siblings in the buggy, perhaps?
Great, thank you. So, issue on healthy places and what can we do? What more can we do? I think the gentleman behind on the table.
Morris Meehan, Public Health Agency, Northern Ireland. Mark talked about the fact that the multiples of adverse childhood episodes are really become highly problematic for later life and so on. So I think the issue then is, if the Royal College of Psychiatrists in England are saying that CAM services are working with largely a workforce of a focus of children from 8 onwards, and if we know that the detrimental effect for infants and not the 3s who are experiencing multiple adverse episodes, and So I think the issue is who's working with that group. How are we assessing the levels of risk for those children at the youngest stage, and what are the interventions, and particularly, I suppose, how we can be. One of the challenges we have in Northern Ireland through our new infant mental health plan is how we can get CAM services to think about a more balanced approach to thinking about their capacity to engage with very young children, very tough work. Certainly, I've been hugely impressed with Graham Shulman's work in Glasgow CAMS and some of the work in North East London.
Brilliant. Thank you so much. And of course, this is an issue which I think is of import across all of the countries. Is there a final quick question? I'm sorry, right at the back, and then we will right in the far corner. So I'm going to ask, after this question, each of the panel members to take 2 minutes to either reflect on one of the questions that you've heard, or if you have any closing comments, sort of call to action that you'd like to leave with us. But we'll hear the final question.
Thanks. Owen very eloquently just asked us a question about did we really value our children? And Catherine described really clearly that there has been significant investment in early years within Scotland. But I guess the challenge for all of us is how do we sustain that? Because Margaret gave a really clear example of how difficult it was for boards to, if you like, almost ring fence and sustain preventative spend against all the other challenges they have. So my question is, when Mary mentions the question how we move towards targets for preventative spend, how realistic are they, and how do we generate a groundswell of opinion for them?
Okay, thank you. So I'm going to start with Eustace, and then we'll move across the table. So any final comments or quick responses?
Just one really, because I suspect the other panel members will reiterate what I was going to say for the second point. But the first point really is just welcome the point that was made around adolescence. It almost feels like they're the forgotten generation in our rush, quite rightly, to push the case for investing in preconception and in early years, which is absolutely the right thing to do. It can feel like sometimes we're saying, well, you don't need to invest in adolescence because we've lost the battle there. And actually we've seen with behaviours that that's not the case. It's also worth reminding ourselves that it's the second most important period, an intense period of social and personal development in a human being's life. So investing in adolescence is absolutely the right thing to do.
Great, thank you. Mary?
Okay. I guess on the adolescent issue, I'd say we really need to use our skills much more effectively, and we heard about that eloquently earlier today, as well as provide specific services for adolescents. On environments, I think absolutely, and the opportunity of community planning to change environments, to create walkways, calming, all of that, absolutely. On the multiple issue of ACEs and CAM services, I think that's within our gift within health and social care to shift resources downstream. It will mean moving them around, but it's within the system. So there's something very doable about that, as well as upskilling the workforce. But finally, the point about targets and investment in terms of the programme for government, I think that's the big prize. And we have got to keep pushing for that setting of targets for not just preventative spend, but a focus within and across government.
Lovely. Thank you, Mary. Owen?
Grand, thanks. I think learning is much more difficult to achieve, if not impossible, if you don't have the right relationship, if the relationship isn't right. And that's right across the board. If it's your Director of Public Health with your Director of Local Services, if you're Minister of Education with your Minister of Health. And I think that's something in terms of a whole systems approach and a whole of government approach. Despite the aspiration and the requirement for that, there's still not enough premium placed on actually doing that. And it has to become somebody's responsibility to coordinate that collaboration. Frequently it's just left and it's everybody's business. But if it's everybody's business, in a sense it becomes nobody's business. So you have to have accountability and mechanisms to achieve that. Just a final point, I think one of the things is consultation. So that consultation conversation really has to happen with the young people on the issue of inequalities in the same way that it's happening maybe around obesity for the obesity policy in the Republic of Ireland.
Thank you, Owen. Ruth?
4 quick points. In terms of what can we do in the very early years, and it was before children go to school, my sense is we need to push very hard to integrate our approaches. I visited a children's centre in part of Cardiff only a few weeks ago, and to listen to how they understood what was happening to families, changed the response accordingly, knew every child in that school, was consciously focused on multi-agency working. The health visitor says, I can pick up the phone to housing, they get it sorted within a short space of time. That partnership, getting out of our silos, really driving hard. And listening to the leader of that centre say to me, do you know, actually people are staying in the area because this is such a focal point for their families. Dads coming on Saturdays with kids to play football, a whole set of things. So how do we regenerate communities but use the catalyst of the Children's Centre as an approach? Secondly, school curriculum, or schools generally. We talk about healthy schools, but I was absolutely bowled over when the policy decision was made this year that the curriculum in Wales would be changed, school curriculum. So there were 4 overarching purposes of education, one of which is health and well-being. And now that is now being taken forward integral to the whole of school life and an outcome of school experience. So I hope that will bring that universal focus to children as they go through adolescence. Thirdly, I'll be quick, creating safer communities. Absolutely, children in the most disadvantaged areas experiencing injuries, avoidable injuries. It links to my next point, which is how do we get a unified narrative? We often, if you like, campaign and communicate on a single issue. And you know, it's how do we make sense of the whole story? And somehow get across how all of those things play together and why we actually need to work on a number of things together. So I leave that as the challenge, and I'd welcome your advice over lunch, is how do we tell that story in a way that doesn't diminish the complexity but simplifies it so we understand what we can do.
Thank you, Ruth. And Catherine, final word.
I'll be brief, and I'll maybe just John O'Dowd's question about how do we sustain this investment for our children. So that's why we are all here. We believe that this is the right thing to do. I think we touch on the importance of the child and the child in their own community. I was at a school in the west of Scotland, which is actually in a park, in a public park. There's a leisure centre in the park as well. And the teacher said, well, when it's a nice sunny day, we take the physics experiments and we sit outside in the park. And the school runs a programme for both the pupils and the parents about health and well-being. So that is a real community asset. I think our difficulty is, and Ruth's just touched on this, have we proven our worth, if you like, with the investment for children? We have endless discussions about cardiovascular disease in older people, in investment in drugs and treatments that will make people healthier. But in fact, it isn't too long an investment for children. I can change a preterm delivery in 9 months. We can change obesity rates in children within 2, 3, 5 years. So I think, John, we need to prove that what we're saying is true, and we maybe haven't done that well enough. So if I could go to a politician and say, we reduced smoking in pregnancy by X%, and the preterm delivery rate has gone the same direction, and that has saved X amount of services, but also educational attainment, etc., etc. So I think particularly in a hard-pressed financial climate, everything we do, we need to make sure that we're proving that we're value-added. And this community, and all of us in this room as leaders in this area, we are value-added, really. And we just need to get out there and prove that.
Great. Thank you, Catherine. Colleagues, please join me in thanking the fantastic panel this morning. So we will break for lunch now. We started a bit late, coming from our earlier break, but we'll have lunch now, and we'll have some instructions on the workshops, which will immediately follow lunch.
Thank you. We'll split the difference with the timing and start the workshops at 2:25 instead of past. If you could go straight to the workshops after lunch. The workshops that you're allocated to, you have coloured dots on your badges. So those with green dots on your badges are going to a workshop around protecting vulnerable pregnant women and very early years, and that workshop will be in here. That's the green group, will be in this room. Anyone with a black dot on their badge, don't panic. It just means you're in the workshop around adolescence and childhood trauma. And that will be in the GB Ong room, which is just downstairs next to the registration desk. The red workshop is called Children in Trouble, and that takes place in the building across the courtyard from here. So if you go out the door, you come in, and there's a door for that building straight across the courtyard. If you turn right along that corridor, and then at the end of the bookshelves, you'll see a room to the left. And there's a notice on the door. It's called the reception room, and that's for children in trouble, the red group. And finally, the yellow group is also in the building across the courtyard, and that's about food and poverty. And that is, if you go into the building, you'll see sorry about this, but you'll see a notice pointing towards the gents' toilet. If you take that corridor and then turn right at the end of the corridor, and then the room is just to the left, that you'll be in. And again, there's a notice on the door with a yellow sticker, and that's food and poverty for the yellow group. Okay, thank you very much. See you later. Lunch is downstairs. Important information.